Dr. Greenstein, thank you so much for taking time to speak with us today. I just want to ask you a couple questions about billing and coding. My first question is, why do you think billing and coding is unique or maybe cumbersome in the field of urology?
Thanks, Summer. Thanks for having me for these interviews. This is nice. I don't think that billing and coding is cumbersome specifically to urology. I think billing and coding is cumbersome. It's its own language. It's its own unique way of people talking to each other. So you can say, did you see the level 4? Did you see the level 5? Did you see that modifier patient? It's just way of us communicating with the healthcare systems like Medicare, Blue Cross Blue Shield, and Cigna about what level of care we're providing. And so I don't think it's cumbersome to urology. I think it's cumbersome to everybody. There are rules. There's rules for rules. There's things called bundling. There's things called unbundling. There's edits. There's modify. It takes a long time to learn, and it's a very frustrating system. It's imperfect, but it is what it is. It's the best that we have.
So what do you think is the biggest issue with billing and coding that private practices are facing today?
So I think the biggest thing is the denial. We're seeing a lot of insurance companies, not Medicare, but the Blues specifically, and maybe some other private carriers that are saying, we don't believe this is a level 4 visit. We think it's a level 3. And so they deny. And in order to get reimbursed for the work that you provided, they're requesting notes, or we have to send our notes for them to review. So the frustrating part is you're going to do all this work with a patient. You're going to spend time with the patient. You're going to order medicines. You're going to order a CAT scan. You're going to do things like that. And then someone's going to say, nah, I don't trust you. Then you have to hire somebody to go through that, submit it to the insurance company. So you have to pay that person's salary to do that so that you can get paid for what you've already done. And to me, that's the biggest frustration. The second frustration is trying to negotiate all these modifiers that are out there and making sure that they're used properly, because I think a physician should take ownership of what they're coding and what's going on. And there's some things that I don't worry about with coding, but there's things that I want to make sure that get coded properly. If I spent an hour with a patient organizing their workup for prostate cancer, because sometimes I have to do that, and I bill, say, a level 5 because of all the tests that I'm going to order, all the risks that I'm discussing with them, stopping blood thinners, whatever I have to do for them, an insurance company says, nah, it's just a level 3 visit. You know, it's unfortunate. It's like going to your accountant and then your accountant says, well, I just did your taxes. I did your financial planning. Here's your bill for, say $500, which it's not going to be that low, but let's say it's $500. They're like, I'm just going to give you $300. Thanks. Have a nice day. It doesn't work that way. But in our world, it works that way. And so for me, it's the frustration of these denials that the insurance companies do.
Wow, that is alarming. So can you explain a little bit about how coding in urology overlaps with like oncology, pediatrics, endocrinology, gynecology, gastroenterology, et cetera, and how this would affect your next in terms of billing?
So, sure. So in certain fields, we do procedures. In certain fields, there's no procedures. So for example, a pediatrician is not going to be doing, a general pediatric physician is not going to be doing procedures in their office. They may draw blood, but that's not really a procedure. That's a separate code for a venipuncture. An oncologist is not going to be doing tons of procedures. Maybe they'll do a bone marrow biopsy every once in a while, but they're mostly just doing consultation work. Whereas procedures done by physicians require the knowledge of modifiers and the understanding of a surgical code versus a visit code. So for example, a dermatologist may see a new patient for a mole concerning for a melanoma. And that visit was, say, 25 minutes. They spent time talking to the patient. They talked about melanoma prevention. But by the way, there is a mole on your back that needs to be looked at. And they make a decision to do that little biopsy or shaving of that mole at that time. I would hope that the dermatologist would bill that as a new visit, level 4, because that's what I think it would be, modified with a 25 modifier, because they're doing a shaving of a skin lesion, whatever that code is. I don't have that memorized. But then you're hoping that the insurance company is recognizing the work that you've done, instead of saying, well, we're just going to pay for the shaving and we're not going to reimburse you for the time that you spent talking to the patient about evaluation and screening for melanoma. And so in urology, that's the same thing. We do a lot of procedures on the same day. So we may have a day where a person comes in with gross hematuria, brand new patient, they're on a blood thinner, because we see a lot of that these days. We spend time with them, we examine them, we review their medications, we talk to them, all that stuff, and we make a decision that this person needs a cystoscopy right now. Why? Who knows why, but we're making that decision. So that's we'll say a level 4 visit. We need to use the 25 modifier, and then we're going to use the 52000 code for cystoscopy on the same day. And we're hoping that the insurance company says, okay, I got it. You made a same day decision. You're getting reimbursed for a procedure and EMN code on the same day. Here's your payment. At the same time, we have our surgical codes and the surgical codes that involve with what we do for a living. So for example, on a day where you're not seeing patients in the office, but you're just operating, it would be wise for our urologist to know his codes or her codes when they're doing, we'll say, complicated ureteroscopy. So if you're doing ureteroscopy with retrograde pyelograms and a stent, the 52356 code is used, and you're hoping that your billing company is doing the right thing and making that code into the chart so that the insurance company says, oh, look at that. We did a ureteroscopy. We did a laser. We put up a stent. Here's your code. And so the issue for specialists is the idea of knowing your modifiers, knowing your procedure codes on top of your office visit codes.
So that leads me to my next question. Why do you feel like it's important for a resident or a new urologist, like 1 to 5 years into practice, to know billing and coding basics?
So let's re-ask the question to a person who owns a business. And let's say a person wants to open up a pizza shop. They went through college, maybe they went to business school, and they said, you know what? And let's say that they worked on Wall Street or in downtown Atlanta, and they worked for JP Morgan for a little while. They got their feet wet and they're like, nah, I'm just going to open up a pizza store. That person is going to know exactly what they're buying, exactly what they're paying, what their insurances are, what their parking lot is like. Because if they don't, they're going to have a failing business. They need to know how much mozzarella costs, how much the dough costs, how much the sauce costs, what the rent cost is, because that's running a business. And unfortunately, medicine is a business. It is not the mom and pop shops like we know from the 80s and 90s or 70s, 80s and 90s, where you hung a shingle, you saw patients, and you were paid pretty comfortably. And now it's a business of you need to know what's going in and what's coming out. And so if you're spending time managing people's health and you're doing certain levels of visit and you're doing certain procedures, I think every physician has a right to know what they're billing, what they're reimbursing, what their overhead is. It's just my personal opinion. Some people don't want to know. Some people are just like, I'm just going to do my work. It is what it is. But to me, I think you have a right to know that Medicare is going to reimburse you a certain amount for doing a cystoscopy. And your Blues, your Aetnas are going to reimburse a certain amount for doing a cystoscopy. And by the way, you've switched over to a disposable scope, so there's cost involved. And you got to buy some saline, and you got to kind of know what your rent is. So I think it's kind of important to know the overall picture of running a business, because that's what private practice is. It's running a business.
Let's say you have a resident. Should a resident really be informed about how billing and coding is being handled at a specific practice before they decide to take a position there?
I think so, because no matter what the position is, someone's going to be giving that physician feedback as to what they're doing for a living. Now, let's divide it up into 3 categories. Academic, so in other words, they go to a university, they're working, say, 3 days a week, but 2 days a week, 3 days a week as a clinician, but 2 days a week they're in a lab. Okay, they're running some lab for the hospital or for the university. Then you have employed physicians that are employed by a big corporation, say like health center. I don't know. Let's come up with a name for a university. And then let's say you have someone that's private practice, and they're in a group of privately owned group of offices, each owned by, we'll say, a managing company, or even they're all partners or something like that. There's going to be money going in and out of that practice, income going in and out of that practice, or there's going to be something called RVU, the value units that are set aside by Medicare that tells physicians what level of work is done on a surgery or an office visit or something like that. So in the world of procedures, a nephrectomy is going to have more RVUs than, say, a cystoscopy. A cystectomy is going to have more RVUs than, say, a simple prostatectomy. And so I think that no matter what, a physician needs to know that level of service that they're providing to whoever's employing them, or even if they're self-employed. So if a person's owned by, is employed by a big hospital practice, and let's say they're generating a certain number of RVUs a year, but that doctor says, I'm special, I need a raise. Look, I'm working 80 hours a week. I'm seeing 120 patients a day. I take only 3 weeks of vacation, and I think I deserve a raise. But if the hospital assistant comes back and say, listen, Dr. Smith, you're only generating X number of RVUs, you're not making that much money. I think that physician has a right to know that. And in the same thing in private practice, if a person in private practice is working hard and they're generating certain amount of cases and certain amount of healthcare, they have a right to know what they're doing, because that's just my personal opinion.
So what are some common mistakes you believe that happen in coding that could lead to a rejection of a claim?
There's no simple answer for that. So there are a lot of things that can go wrong with the coding. It could be something as simple, you spelled the name wrong. So something happened with the computer, name got spelled wrong, it gets rejected. Date of birth, rejected. Wrong insurance information, that's a big one. It's very common for patients to come in, they got last year's insurance card, rejected. They forgot they didn't put their social security number down. I'm making that one up. Your note is incomplete. So you spend time dictating your note, you forgot to put in a diagnosis code, rejected. Or the insurance company thinks you've billed improperly. You billed a level 5, they say it's a level 3, rejected. So there's a lot of things that go in that small time frame of sending out a billing statement and getting your payment back.
So what is the domino effect of when the claim is rejected? Then what happens?
Ooh, it's practice dependent. So there's a term out there, I think they call them the scrubbers. They scrub the notes before that they scrub the bills before they go out. And so they're looking for the imperfections of trying to get things to go out smoothly so that you don't have to do the behind the scenes work of resubmitting your note, retyping up a name, re-entering something in the computer. And so there's a little bit of a beginning phase before even something goes out so that it's not done incorrectly. But if something comes back in our practice, we do have a team of people that looks and says, oh yeah, Greenstein, you moron, you forgot a diagnosis code. Or, oh, that was our fault. We forgot to put a 0 on the end. Or the note says benign prostatic hyperplasia, and we built it as status post hysterectomy. A lot of times it's just human mistake. So there's a lot of checks and balances to make sure that all this stuff works well.
So what does undercoding mean, and how does this affect net income long term?
So undercoding means that a physician says, I don't care what the code is, but everybody I see today is going to be a level 3 visit. I don't care what they are. I know I could spend 2 hours with the patient. I'm not going to bill on time. It's a level 3 visit, or it's a level 4 visit, but it's actually a level 5 visit. Or let's say you see somebody and you spend 25 minutes with them. You're just talking with them. You don't prescribe anything. There's no testing. You just needed to have a little chat with a person about stuff. That's actually a level 2 visit. And so you bill it as a level 2, but you can actually bill it based on time. And so technically you're undercoding. Depends on the formalities. But the idea of undercoding is one that's actually frowned upon, because if your codes ever or your charts ever get edited, you can actually be fined for undercoding. So you think you're trying to do yourself a favor by not coding too high when you're actually doing yourself a disservice by coding too low. And then an insurance company or Medicare or whatever will look at your stuff and say, wait a minute, what's up with this guy? He saw 20 patients today. They're all level 3. Ding, 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 something's off. Go audit that guy's charts, and you can get in trouble. The other thing is just the financial loss. Doctors have contracts, hospitals and universities have contracts with insurance companies, not Medicare. Everyone's got a contract with Medicare. Medicare is a set rate. But they have contracts with these insurance companies to say, this is a level 3 visit. This is a level 4 visit. This is a level 5 visit. And if you undercode, let's say a level 3 visit is $50. Let's say a level 4 visit is $75 and a level 5 visit is $100. If you keep undercutting yourself, kind of not paying yourself properly for the work that you've performed.
Wow, interesting. So what does prior authorization mean, and why is this important?
So prior authorization is basically the insurance companies telling you, the physician and the patient, that they don't want to pay for something. So in other words, in their infinite wisdom, they say, you're Dr. Greenstein, you're wrong. You should not be ordering this. You should be ordering something else. We have to do a prior authorization. So even though the doctor went to college for 4 years, I'm going to be a little dramatic here, 4 years, they went to med school for 4 years. They then did a residency for, say, 5 or 6 years. And then they've been in practice, say, 10 years. And you see a person with a rising PSA. They have a mass on their prostate. And the doctor says, in my clinical judgment, you need an MRI before you go and have a biopsy. The insurance company will say, no, that's not in our checkboxes. We need prior authorization. So in other words, they now are going to waste your time. They're going to require a phone call from somebody in the office, whether it's you, a nurse, a mid-level, and talk to someone who's probably not a urologist to say why you think this person needs an MRI before you do a biopsy. And so prior authorizations are a huge waste of time. All they do is they drive up healthcare cost. They do not save cost at all. And there's actually proposals in the government to try to get prior authorizations eradicated. And we can only hope that they do so.
Yes, agreed. So can we talk about billing liability? Who does that ultimately fall on?
Billing liabilities? Well, it's always the doctor's fault. Don't you know that? It's always my fault. And so we're kind of the masters of our domain here. And so billing improperly, even if you, let's say you had a physician that was billing improperly. No, let's say a physician who didn't even do his billing. He did the notes and he had a whole team that decided the billing aspects of that note. In other words, the doctor just plays a doctor, the billing people play the billing, and that was their relationship. My understanding is it's still going to fall on the doctor's hands. I don't think it's going to fall on the biller's hands or on the coder's hands. But I'm not too familiar with the liability aspects of that, unless it's the undercoding and overcoding, because that will generate audits and that will generate problems for the physician.
Interesting. So how does policy in DC affect billing and coding? Like, are there any examples that you can provide?
So the government sets the standards and then the private carriers usually follow. So if Medicare gives something a code, it's then up to the private carriers to follow that code. So for example, when a new surgery comes out, for example, let's use aquablation as an example. When something comes out new, there's no code. There might be a G code, there might be an experimental code. You might use what's called a 99 code. In other words, it's a prostate surgery that's unspecified or unlisted code, I think that they call it. And then it's generating more work on the billers to try to get payment for something that they don't know that the insurance companies don't know what to do with. I kind of drifted a little bit there. But Medicare sets the standards and then the private carriers follow. So if Medicare says, hey, we have got a whole new code for you, it's the ZZ code. ZZ code means that if you use a disposable scope, you should be reimbursed a little bit higher for using a disposable code. Let's just make that up. And so you do that. You do 52000 ZZ. And instead of Medicare paying you $150, Medicare is paying you $152. So you need to know that stuff. You're then hoping that the private carriers are going to start following. And so that if you use that code, they're going to say, oh, you're using the disposable scope code. Great. Now we have a whole new set of reimbursement for that. The problem is that some of the insurance companies don't follow that. And I remember being in practice 20 years ago. I remember being on the phone with a Blue Cross Blue Shield agent, and they said, well, we don't recognize the 25 modifier. So that's a code that's been out for a long time. It is a recognized code. They said, we don't recognize that code. We don't use it. So in other words, if you do an office visit and you do a bladder scan at the same time, so let's say you do 99214, level 4 of office visit, you write for a prescription, you go through their meds, you say you need diagnostic testing done, you need some blood work, a level 4 visit. And when the patient is in your office and you do a bladder scan, which is 51798, you're supposed to use the 25 modifier, telling the insurance company, I did a little bit of extra work, please pay us for both, okay? They said, we don't recognize that code. Can you imagine that? And so we're hoping that policies from government will say, no, you got to follow the rules here. You can't do this prior authorization garbage. If a doctor says he needs an MRI or she needs an MRI, get an MRI. Don't do this prior auth garbage. Here's the codes. We got books on it. We got rules on it. Follow the rules. Be respectful. So that's all we can do is hope and just fight. And that's why they make lobbyists to work for us.
Yes, let's hope. So a couple questions here. How long did it take you to feel like you understood billing?
So I've been in practice starting my 20th year any day now, and I still don't understand it. It's still a nightmare with all the edits and the codes and the adjustments. It's still something that is a work in progress. They've just changed the E&M system. For years, the E&M system was a set thing for a very long time. About a year and a half ago, they changed it. So we had to learn a whole new system of coding and putting notes together for an office visit. I think it's for the best. I think it's for the better. It eliminated the use of review systems, which was for a urologist, not a wonderful thing to use, but it's a whole new thing that we had to use. And then a few years ago, they changed the symptom codes and the diagnosis codes. It used to be BPH, I think it was 600.01. Urgency had its own code. I used to have it memorized because we used to use these codes every single day. They changed it. They made it more complicated. Stones are now N20.0, but a stone in the ureter with hydronephrosis is N13.2. And it's like just mind-boggling on trying to remember this stuff so that you can get this into your note so that you can then get properly reimbursed for what you're doing. I think a resident needs to know that when you're doing, for example, a ureteral stone and a kidney stone at the same time, there's ways of coding that so that you are properly reimbursed for the work that you've provided. There's codes for working on two different sides. The resident needs to know that if you do, say, a ureteroscopy on the left side, but then do a ureteroscopy on the right side, which sometimes is standard of care, there's a 50% reduction in your payment towards one of the sides from some insurance carriers, if not all insurance carriers. So a resident who just came out, remember, 4 years of college, 4 years of med school, 5-6 years of residency, you want to be able to earn a living. You want to be able to do business. And if they learn, wait a minute, I did all that work, an insurance company says you only get 50% of your work, they need to know that because that's the world. That's what it is.
Wow. So lastly, if you had a magic wand and you could make changes in the industry, across the industry with billing and reimbursement, what is one change or one or two changes that you would make?
So that's a textbook. That's not a simple answer. That's oh gosh. I think the one thing would be we should be reimbursed for the work that we do. End of story. If someone does a 2-hour radical prostatectomy, someone is cured of cancer, I think it'll be nice to have that doctor reimbursed comfortably for the work that they've done. If you look at other professions, a lawyer, an accountant, an engineer, they're reimbursed for their time. They're reimbursed for their expertise. In healthcare, we're cut short. The companies say, well, we only think you're worth $200. We only think you're worth $400. Now, with that said, no one should practice medicine based on money. That is the wrong thing. You know, you can't look at a patient and say, ooh, urodynamics and ooh, a kidney stone and that's terrible. That's unethical, that's immoral. And so they should never practice that way. But it is a business and you have to keep your lights on and you have to keep your staff paid and you have to pay your rent. And so I think you have to know what you are doing so that you can comfortably understand the ins and outs of practicing medicine on a business level. And so ideally, I think it'll be nice for just all these insurance carriers, Medicare, Medicaid, Blues, Aetnas, Uniteds, all those people out there would say, oh, you know what? Let's just pay what this guy is doing. But obviously, if something's way off, let's just do a little investigation to make sure that things are okay and we're not missing something from an insurance standpoint. but I think it would be nice to be reimbursed for what we do.
Awesome. Thank you so much for your time today.